This is Chris Streck, and on behalf of my co-moderator, Shannon Castle, we'd like to thank all of our presenters today. We have the following format, which is that we will have a research abstract presentation followed by a clinical practice guideline. The three general topics that we're going to cover today are evaluation and management of pediatric blunt abdominal trauma, defining TEG abnormalities in pediatric trauma patients, and monitoring and goal-directed therapy for massive transfusion. And finally, information about identifying and managing child abuse.
Hello. My name is Alyssa Butler, and today I'll be talking to you about surgeon choice in management of pediatric abdominal trauma. We have no disclosures. There's currently no standard of care for management of the hemodynamically stable patient with concern for hollow viscous injury, and there's evidence that there is significant variation in management of pediatric abdominal injury nationally. Given this variation in management and the lack of evidence-based guidelines, the objective of our study was to determine what patient, surgeon, and facility factors contribute to choice of management in pediatric abdominal trauma. We created a survey tool of 5 clinical scenarios of a 9-year-old hemodynamically stable boy with abdominal injury. For sake of time, I'll focus on the first 3 scenarios, which were isolated blunt abdominal injury with severe multi-system injury, and blunt abdominal injury with severe TBI. For each scenario, surgeons were asked to choose between observation, diagnostic laparoscopy, and exploratory laparotomy. The questionnaire was sent via email to surgeon members of EAST and APSA, and eligible participants were those who care for children less than 15 years old with abdominal injury, who are not current trainees and who completed the entire survey. Our analysis was a multivariable logistic regression looking at the association between specific factors and observation versus operation, and then for those who chose operation, laparoscopy versus laparotomy. The factors included in the model were injury type, surgeon type, years in practice, and highest facility trauma level. Emails were sent to 1,800 members of EAST and 866 members of APSA, and our overall response rate was 22%. Our final analysis included 394 surgeons. Of those surgeons, about half were trauma surgeons and half were pediatric surgeons. In terms of characteristics, pediatric surgeons tended to be in practice longer, and most surgeons practiced at an academic medical center. Most surgeons practiced at an adult level 1 trauma center, and most pediatric surgeons practiced at a level 1 pediatric trauma center. However, nearly half of trauma surgeons practiced at a facility with no pediatric trauma designation. Here we can see the results of the operative choice by type of surgeon and the scenario. For the isolated abdominal trauma scenario, most surgeons chose observation in the dark purple compared to diagnostic laparoscopy in the gray and exploratory laparotomy in the gold. Overall, pediatric surgeons tended to choose observation more frequently than trauma surgeons, and if they did choose an operation, they more frequently chose diagnostic laparoscopy over exploratory laparotomy. In terms of our multivariable logistic regression, we found that compared to isolated injury, those with severe multi-system injury and those with traumatic brain injury, surgeons were more likely to choose operation over observation. However, independent of the injury type, pediatric surgeons were less likely to choose operation over observation. But those who did choose an operation, surgeons were more likely to choose laparotomy over laparoscopy for the scenarios with the multi-system injury and with the traumatic brain injury compared to the isolated case. However, pediatric surgeons were more likely to choose laparoscopy over laparotomy independent of the scenario. So our study does have a few limitations. Given that it's a convenient sample of members of EAST and APSA, it's potentially not generalizable to non-academic and non-trauma centers. Given our limitations in the length of the survey, we were not able to assess all factors that may affect surgeon choices, and our relatively low response rate may have resulted in some non-respondent bias. So in conclusion, we found significant variation in surgeon choice of management of children with abdominal trauma, and it depended on patient injury type, but also surgeon training and experience. Based on this, evidence-based guidelines are necessary to guide surgeon management. Here are my acknowledgements, and thank you very much, and please contact me with any questions that you have.
Alyssa, thank you for a well-described survey and a very nice presentation of your work. My bias is that abdominal CT has progressively become more sensitive for hollow viscous injury over the past decade or two. My 2 specific questions are as follows. 1, have we pediatric surgeons been lulled into a false sense of security by taking care of so many non-op traumas, or are we changing the paradigm for the benefit of the patient like we once did in splenic trauma? Secondly, an interesting finding from your survey was for those surgeons that preferred laparotomy over laparoscopy, they did not seem to choose laparotomy for the reasons that were advocated to me as a trainee during my general surgery training. At that time, laparotomy was felt to more readily identify injuries to the pancreas and bowel and was considered faster, at least in terms of this setup.
Thank you, Dr. Strick, and for those excellent questions. With regards to Dr. Strick's first question, whether pediatric surgeons are kind of lulled into a false sense of security in terms of taking care of mostly non-operative trauma, I think it's hard to know. A lot of trauma these days is non-operative, both for adult surgeons and pediatric surgeons. I think the big shift in paradigm in management of solid organ injury we've seen, where really abdominal surgery for trauma is not occurring very frequently, particularly in the hemodynamically stable patients, like in this survey. I don't think that the results of this survey are just findings different between adults and pediatric surgeons because of their management of operative trauma. I think it's probably more related to their experience in training and really the kind of lack of evidence-based guidelines. So I think it's much more related to an individual surgeon's experiences. And then in terms of the second question, why some surgeons are still choosing laparotomy over laparoscopy, I was able to ask that question in the survey. With each scenario, surgeons were asked why they chose laparotomy. And really, it actually is pretty similar to what you were taught in training, Dr. Strick. The first, most common reason people chose actually was that they anticipated a need for an intervention that they wouldn't perform laparoscopically. So, be it a small bowel repair or pancreatic resection or something like that. But then the second choice was better visualization. And so I think a lot of surgeons still feel that they're better able to visualize a bowel injury or a pancreatic injury in an open operation compared to laparoscopic surgery.
So the first practice management guideline is in regards to evaluation of the pediatric abdomen and who needs a CT scan for blunt abdominal trauma. CT of the abdomen and pelvis is commonly used to evaluate children following blunt trauma despite the low incidence of intra-abdominal injury found, the associated cost, and the risk of radiation-induced malignancy. This diagram shows our current clinical practice guideline for abdominal CT imaging in children following blunt abdominal trauma. The clinical practice guideline is a 5-variable model which identifies patients at extremely low risk for intra-abdominal injury in whom a CT of the abdomen can safely be avoided. The 5 variables here on the left are listed in the order of clinical availability and are as follows: complaint of abdominal pain, an abnormal abdominal physical exam. This would include tenderness to palpation, evidence of abdominal wall trauma like a seatbelt contusion or a handlebar contusion, abdominal distension, or peritoneal signs. Third, an abnormal chest x-ray. Fourth, AST greater than 200. And then finally, abnormal pancreatic enzymes, amylase or lipase. If all 5 variables are negative, then the patient is unlikely to have any intra-abdominal injury on an abdominal CT scan. I would also highlight the asterisks next to complaint of abdominal pain and abnormal pancreatic enzymes. These 2 variables had a much lower odds ratio for intra-abdominal injury, so I would highlight that CT is not compulsory in this model if only one of the 5 variables is abnormal and present. To highlight the practice guideline, I chose 2 patients. These are a brother and a sister from the same motor vehicle collision. The first, the brother, is a 6-year-old male. He was a restrained backseat passenger in the MVC. It was a car versus tree, a head-on collision. He had no stated loss of consciousness and was reportedly hemodynamically stable en route. In our institution, he met criterion for a second-tier activation or level B. On primary survey, his airway was patent and his vital signs are as listed. His GCS was 15. On the secondary survey, the only finding was some mild tenderness to palpation over C6, as well as moderate abdominal tenderness to palpation over an obvious seatbelt contusion. The sister in the collision was an 11-year-old female. She was restrained in the back seat. She did state that she had loss of consciousness and was stable en route. Her vitals were fairly stable. GCS was 15. She had several fractured incisors and a minor lip laceration. Her midface was stable, and she had a normal abdominal exam. So some of the main considerations for trauma surgeons are: do you order labs and plain films in the trauma bay? Do you do FAST in your institution? What about a seatbelt contusion? In Alyssa's study, she mentioned In all three scenarios, the patient had a seatbelt contusion. And finally, what if the patient is intubated with a serious blunt mechanism like this, but no signs of abdominal trauma? So back to the two patients. The brother, initial hematocrit 37, his labs were normal. His AST was 49. His lipase was normal as well. And the chest x-ray had no evidence of traumatic injury. In contrast, the sister had two abnormal variables. Her AST was 222, and her chest x-ray showed some pulmonary contusions. Both patients underwent an abdominal CT. This is one representative cut from the brother. There are some small areas of free air and free fluid in the lesser sac behind the stomach. This was read as a suspicious for a hollow viscous injury. We brought the brother to surgery following CT and performed a diagnostic laparoscopy and a lap-assisted repair of a jejunal perforation. The sister also had an abdominal CT, which was normal. In regards to the 5-variable model, the model was derived following a study, which was a prospective study involving 14 level 1 pediatric trauma centers. This slide again highlights the 5-variable model and the percentage of patients with abnormal variable. IAI stands for intra-abdominal injury, and IAI stands for injury requiring an acute intervention. In this study, an acute intervention was defined as blood transfusion, an angiographic intervention, or an operation. As you can see from the slide, approximately 1/3 of the patients were identified as very low risk, meaning none of the variables were positive. Those patients had a 0.6% risk of an intra-abdominal injury and a 0% risk of intra-abdominal injury requiring intervention. An additional 21% of the population were thought to be low risk. These were patients that had a normal abdominal exam and a normal chest x-ray, and who we chose to wait on lab. And in this additional 21% of the population, the risk of intra-abdominal injury was less than 5%, and the risk of injury requiring intervention was less than 0.3%, highlighting that it's likely safe in these patients to wait on labs prior to making a decision about abdominal CT. Our study conclusions were as follows. The prediction rule was most helpful in patients that were hemodynamically stable with a non-concerning abdominal exam. These are patients where there's likely time to get an abdominal CT, and less than 3% received an acute intervention. Most importantly, the vast majority of patients that did undergo operation, transfusion, or angio had an abnormal abdominal physical examination. Finally, abdominal CT scan utilization could be avoided in many patients by implementing the prediction rule. Even at pediatric level 1 trauma centers, over 23% of the very low risk population underwent an abdominal CT. And importantly, we saw significant variability between the centers, ranging from a CT scan use of 4% at one center to 96% at the high outlier. And then finally, we felt that this practice guideline would be very beneficial for the 90% or more of children that were initially seen in adult centers, where many ED physicians feel compelled to obtain CT prior to calling the pediatric trauma center and requesting transfer.
Thank you very much, Dr. Streck, for presenting such a clear protocol for a subject with variation across many institutions. Is there any role in doing a FAST scan?
This is probably the most common question I get asked. In particular, many of the adult ED physicians want to include FAST in any clinical prediction model. So what we found in our study was that FAST had a very low sensitivity for intra-abdominal injury. It was around 28%, and only slightly better for injury requiring intervention at 44%. And impressively, FAST missed the vast majority of injuries, both solid organ injuries like liver and spleen, as well as hollow viscous injuries. The solid organ injuries missed included grade 3 through 5 injuries. So these were not just minor solid organ injuries that were missed by FAST. And FAST also commonly missed patients that required intervention. FAST was initially designed for rapid assessment of hemodynamically unstable patients to determine the need for urgent intervention. It was not originally designed to determine who could safely avoid CT. We all know FAST is operator dependent. And then based on many studies in peds showing worse sensitivity of FAST for solid organ injury, I wonder if there's something different in kids. In conclusion, I do feel that there is a role for labs and plain films, particularly in hemodynamically stable kids with a concerning mechanism. They all don't need CT. I don't feel that FAST can exclude intra-abdominal injuries safely. And based on the practice guideline, I think that it is possible to be selective on who receives abdominal CT. Thanks.
Thank you for the opportunity to present our work. We have no disclosures. Hemorrhage is the leading cause of preventable deaths in pediatric trauma patients. And it's important to recognize that ongoing hemorrhage is due to what is known as trauma-induced coagulopathy, which is a sudden disturbance in our body's ability to form clot following severe trauma. Traditionally, we assess the degree of coagulopathy by coagulation tests, such as the PTT or PT-INR. However, these tests have come under scrutiny as they were originally designed to guide anticoagulation therapy. And often these tests have a time delay before resulting, and they can hinder our ability to quickly treat a bleeding trauma patient. Thromboelastography, or TEG, on the other hand, is a real-time point-of-care test that provides a high-definition global picture of the underlying coagulopathy. It measures not only how quickly we form clot, but also the clot strength and the rate of clot breakdown. In adults, goal-directed TEG has been shown to reduce mortality when used to guide massive transfusion resuscitation. But there remains limited data on the utility of TEG in directing resuscitation of pediatric trauma patients. So we hypothesized that abnormalities on admission TEG would differ in pediatric trauma patients who undergo massive transfusion compared to those who do not. We identified all highest level trauma activations admitted to 2 pediatric trauma centers over our 8-year study period. We stratified patients based on whether they received massive transfusion, which we defined as greater than 40 cc's of blood products within the first 6 hours of admission. And we defined TEG abnormalities based on each institution's normative values and compared TEG abnormalities between the groups. There were 118 children included. 34% of these underwent massive transfusion. The massively transfused patients had significantly lower platelet counts, higher INR values, and an increased overall mortality. We found no significant difference in abnormal R times between the groups. However, over 20% of the patients would have benefited from early fresh frozen plasma administration. We did find that massively transfused patients had significantly shortened alpha angles, and which would suggest that a higher proportion of the massively transfused patients would have benefited from early cryoprecipitate administration. Furthermore, a higher proportion of the massively transfused patients had a decreased maximum amplitude, or MA values, suggesting that these patients would have benefited from earlier platelet transfusion. There was no significant difference between the groups regarding fibrinolysis. However, it's interesting to note that over 70% of all patients combined had some sort of derangement in fibrinolysis or their abilities to break down clot. On logistic regression, after adjusting for age and Glasgow Coma score and dichotomizing TEG values as either abnormal or normal, we identified a decreased MA, or maximum amplitude value, to be a significant predictor for massive transfusion with an odds ratio of 3.68. So in conclusion, pediatric trauma patients who require massive transfusion are more likely to have lower alpha angles and MA values, in addition to lower platelet counts. This suggests the need for increased TEG use in a bleeding trauma patient due to the prevalence of low fibrinogen and abnormal platelet function. TEG provides a real-time information, unlike conventional coagulation labs, which can often take up to an hour to result. Thus, TEG can aid in expediting the delivery of blood products beyond packed red blood cells during trauma resuscitation. Thank you, and I'm happy to answer any questions.
Dr. Phillips, thank you for that very provocative presentation on a topic that's very near and dear to my heart. Your study really does highlight the importance of early and accurate assessment of trauma-induced coagulopathy. So with that in mind, just a couple of questions. Your results are very much consistent with previous retrospective studies, especially with regard to the importance of the maximum amplitude. When you look at your two populations, how did you control for disease severity in your analysis?
I have one additional question. From a process perspective, can you tell me how your institution does TEG monitoring?
Dr. Castle and Vogel, thank you both for your comments and questions. Regarding our protocol for activating massive transfusion at Children's Colorado, we activate massive transfusion based on one of two criteria. First, at the discretion of the treating physician, who predicts blood loss of 50% blood volume within the next 3 hours or less, or evidence of ongoing bleeding in which the patient has already received 40 mLs per kilogram of crystalloid and 20 mLs per kilogram of blood. Our standard massive transfusion protocol involves the principles of damage control resuscitation, and we deliver blood products in a ratio of 1 to 1 to 1. With respect to where TEG fits into our real-time management, one of the first things that we do on all trauma patients is a lab draw. So we're able to send the TEG immediately and have it start being processed right away while we continue our trauma resuscitation. And then when the TEG becomes available, those results are displayed in real time in the trauma bay. So if we're actively resuscitating a patient and see the results come back, at that point, the TEG abnormality takes precedence over sticking to a fixed ratio of blood products. So for example, if we're transfusing and we see that the TEG comes back and the maximum amplitude is low, we would then give platelets next instead of continuing. And I think that this really kind of highlights the true benefit of TEG, is that it really provides an opportunity to individualize resuscitation. Thank you all for your questions.
First, I'd like to thank the Trauma Committee for the opportunity to present this work effort looking at trauma-induced coagulopathy and massive transfusion in pediatric trauma. So this was a joint effort that came out of the Guidelines Committee for the Pediatric Trauma Society and the Eastern Association for the Surgery of Trauma. So we know from a litany of adult and pediatric studies that the more severely injured you are, the more coagulopathic you are, and the more likely you are to die. And we know these relationships hold true whether or not the coagulopathy is assessed with conventional coagulation tests or viscoelastic monitoring like TEG and ROTEM. The purpose of this effort was to provide some evidence-based, specifically using grade methodology, behind some recommendations specifically looking at the role of viscoelastic monitoring, blood product transfusion ratio, as well as massive transfusion protocols in the management of severely injured children. We came up with 4 PICO questions, and the outcome for all of these questions were the same. So they were mortality, total blood products transfused, ICU-free days, and vent-free days. Just some general observations about what we encountered as we embarked upon this effort. So first of all, there were very few studies that made our inclusion criteria. The vast majority, in fact, all of them were either retrospective or prospective observational, and the overall quality of the evidence was low or very low. Because of the nature of the studies, we could only do qualitative synthesis, not quantitative synthesis. So we chose to incorporate and reference high-quality adult literature and guidelines to help guide our recommendations. So let's get into it. So the first question that we asked was, in severely injured children, are initial viscoelastic abnormalities, so TEG and ROTEM, better than initial conventional coagulation test abnormalities for predicting trauma-induced coagulopathy? We started off with 603 abstracts that met the criteria, but actually identified only one study that we were able to include in our analysis. This was a retrospective single-center study of 87 patients. Overall, it was a very low quality due to the nature of the study. The authors did look at mortality, total blood products used, and ICU-free days. And overall, when you take a deep look into their data and their correlations, the viscoelastic monitoring parameters in this study, it was a rapid TEG, had a better correlation with outcomes, things like mortality, blood products transfused, and also life-saving interventions. We therefore concluded from that study, but also again, multiple high-quality adult studies, for a conditional recommendation that viscoelastic testing be considered the better study for predicting trauma-induced coagulopathy in pediatric trauma patients. Our second PICO question really tried to get to the heart of how best to direct a goal-directed hemostatic resuscitated effort in children. Specifically, is a goal-directed hemostatic resuscitation using viscoelastic monitoring compared to conventional testing result in improved outcomes? So of the almost 600 studies that we identified by abstract, we only were able to include 5. So these were retrospective and prospective observational studies, very low quality evidence. There are 5 that looked at mortality, 4 studies that looked at total blood products use, and 2 studies that looked at ICU-free days and vent-free days, respectively. The problem we encountered was that there were no studies that allowed for a direct comparison of viscoelastic monitoring versus conventional testing. So again, we had to rely upon our adult studies to help guide our recommendation. So our recommendation was, again, a conditional recommendation that viscoelastic testing be used to guide goal-directed hemostatic resuscitation in pediatric trauma. The overall quality evidence was very, very poor. But when we looked at the adult literature, as well as the extremely favorable risk-benefit profile of viscoelastic monitoring in the adult study, we felt it would be most appropriate to use viscoelastic monitoring in this setting. The third PICO question really tried to get to the heart of the ratio. So how do we best resuscitate these patients? Which products and at what ratio should we administer them? And the PICO question at hand was, does a high ratio or balanced ratio of plasma and platelets to red blood cells compared to a low ratio or unbalanced ratio of plasma and platelets to red blood cells result in improved outcomes? Of the almost 1,500 studies that we identified, we were able to find 7 that we were able to include in our analysis. Again, very low quality evidence, mostly retrospective and prospective studies, but there were some of the data that lend themselves to a more visual presentation. So this is a study from 2017. This is a retrospective review of the Department of Defense data set looking at plasma red cell ratio and mortality. And they actually found that a more balanced resuscitation and the nature of it didn't actually impact mortality. There was a study that came out from 2019. This is from TQIP data, looking at both plasma to red cells and platelets to red cells, and they actually found a survival benefit both in 4-hour and 24 hours for the more balanced high ratios. And then finally, there was a more recent study done by the Atomic Group looking at 100 patients that were massively transfused, and they also found a clear survival benefit to a more balanced 1-to-1 ratio of red cells to plasma. So we then conditionally recommend that a high or balanced plasma to red cell ratio be administered during resuscitation of critically ill children. There was not enough data to make a recommendation specifically related to platelet to red cell ratio. It was very challenging when looking at these studies to make that recommendation. But again, the limited data that we have in children and the high quality data that we have in adults really makes us make that conditional recommendation for a more balanced approach. Our final question that looked at was specifically related to massive transfusion protocols. The question was, in pediatric trauma patients with trauma-induced coagulopathy, does MTP activation improve outcomes? And again, very low quality evidence. Of about 1,500 abstracts that we reviewed, we were only to include 3 studies. The 3 studies looked at mortality and total blood products use. Overall, the impact of massive transfusion, we weren't really able to show in children that there was a clear survival benefit. Those studies that looked at massive transfusion, children clearly get products sooner. They're able to get more balanced ratio resuscitation sooner. And it is thought that that would have a favorable outcome on mortality. However, again, in the adult literature, there are clear survival benefits to having massive transfusion protocols in place. Based on the totality of the evidence that we had, we conditionally recommend that massive transfusion protocols be used to facilitate the resuscitation of coagulopathic pediatric trauma patients. Conditional recommendations in summary would be for the use of viscoelastic monitoring, TEG or ROTEM in the trauma bay, both to identify trauma-induced coagulopathy and also to direct goal-directed hemostatic resuscitation. That resuscitation effort should be in a balanced ratio, particularly for plasma to red cells. And finally, there is definitely a role and recommendation to have massive transfusion protocols in the resuscitation of these children. Thank you.
This is Hallie Quiros, and I will be discussing our abstract entitled, Can We Increase Detection? A nationwide analysis of age-related fractures and child abuse. Child abuse is a clandestine crisis that can cause premature mortality and long-term morbidity in its victims. According to a U.S. Congress report, up to 1.3 million children are maltreated every year in the United States. Many fractures are deemed sentinel injuries or injuries associated to abuse, and up to 20% of these injuries are missed by healthcare workers. However, there remains a paucity of literature on screening tools for fractures, particularly when considering the age of the victim involved. Screening tools can aid in the detection and prevention of future cases of abuse. Certain types of injuries, such as abusive head trauma and bruising, have injury-specific screening tools. However, an injury-specific tool of abusive fractures is lacking. Thus, we sought to analyze a nationwide data set of children with fractures of abuse to determine if specific patterns emerge with respect to the child victim's age. And then we performed an analysis with chi-squared and Bonferroni correction as necessary. The cohort consisted of 10,000 fractures. The majority were infants, 60% were male, and half were Caucasian. Multiple fractures were evident in 28% of the cohort, and infants were the most likely to sustain multiple fractures. Head fractures made up 39% of the cohort, with closed skull fracture by far the most common. After age stratification, infants had the highest rates of skull fractures without coma. However, young children aged 5 to 8 had the highest rates of skull fracture with resulting coma. And while uncommon in the younger children, adolescents had the highest rates of facial fractures of all age groups. Upper extremity fractures comprised 25% of the total cohort, with 61% being humerus fractures. The two youngest groups, infants and toddlers, had similar rates of humerus fractures. However, with age, these fractures became less common. This same phenomenon was seen in radio-ulnar fractures, although overall were less common. Adolescents, however, were more likely to have sustained hand fractures, and the incidence was seen to increase with increasing age. 35% of the cohort had lower extremity fractures, with 73% of these being femur fractures. Femur fractures had the highest rates in infant and toddlers, while decreasing substantially in incidence with the child's age. Ankle and foot fractures were seen in children 9 to 12 years of age, although these were more rare fractures overall. Adolescents had the highest rates of tibia-fibula fractures when compared to other age groups. Torso fractures comprised 31% of the total cohort, with ribs being by far the most commonly fractured. The infants had the highest rates of multiple rib fractures when compared to all other groups, and while elementary school age children had the highest rates of clavicular fractures, these fractures overall were less common. This study has some limitations. We use the KID inpatient database, which utilizes the ICD-9 coding scheme, and thus we rely on accurate coding to do our analyses. This also requires prospective validation to validate the results. However, this study demonstrates that when a child comes in with a fracture, that age matters and certain age-related fracture patterns exist. Fracture etiology can be very difficult to determine, as fractures are often due to accidental causes in children. However, we hope that this study helps show that older children still suffer abuse and that their fracture patterns are definitely unique to their younger patients, likely due to changing mechanisms of abuse as a child ages. Thank you. I'd like to take any questions.
Dr. Quiros, that was a very exciting and somewhat depressing set of data. I think your presentation was excellent, but every time I hear of abuse and all the many ways that children are hurt and injured, it brings a lot of sadness. And so in your study, I was just curious, as you know, abuse is a legal construct. How were you able to determine that it was actual abuse at the end of the day? I know you were kind of hamstrung by an administrative database, but were there other data points that led you to believe that it was indeed abuse and not a rule-out abuse?
Dr. Upperman, thank you for that question. So we look into the diagnoses codes, and these databases, as they are administrative, work off of the ICD-9 coding scheme. However, these are this is the HCUP database, which is extremely vetted, and they verify a lot of these the discharge summaries. However, these are not legal definitions; these are clinical diagnoses. So, other things that we looked into to verify kind of that these are abusive fractures, we looked into many of them had skeletal surveys. Many of them had a lot of the workups that are associated with abuse, and they also had other patterns of injuries such as burns, contusions, and other injuries that are associated with abuse. Unfortunately, I think a lot of the child abuse literature suggests that we're not overestimating, we're actually underestimating, especially in the population that we're looking into, that these patients were admitted. We're not even looking into patients that were seen in the emergency room and discharged from ER with a cast or something like that. So the patients that we're looking into were admitted, and likely admitted due to the abusive nature of the fracture.
So as you build this model, were you able to run some of the other models that you mentioned during your introduction and to sort of crosswalk the validity of where you were going with your model?
So this is a descriptive study. So we're essentially not saying that these fractures are indicative of abuse, more that we're walking it back. So these were kids that were diagnosed in the hospital for abuse, and then we're looking back and trying to see if there's any patterns associated with that, and especially with age. Our idea was to look into especially grouping the children into developmental stages. The literature describes a lot of the infants and sub 36-month children, which our study confers with, that they have higher abusive head trauma, multiple rib fractures, long bone fractures. What our study does essentially is really describes more what's occurring also in your older children and your adolescent children.
Thank you. Very well done presentation, and I look forward to the final manuscript. I think that non-accidental trauma and abuse continues to be the scourge of our trauma universe, and I think the more information we know to protect children, the better off society will be. Thank you very much.
Thank you, Dr. Upperman. Hallie, that was an excellent presentation, and I wanted to tag on to Dr. Upperman's comments and questions. When you suggest findings such as elevated skull fractures in infants, what exactly is the point that you're trying to drive home to the audience?
Thank you for that question, Dr. Escobar. So I think that it's more of keeping a high index of suspicion anytime you see a kid with fracture. The literature has well described the abusive head trauma found in younger children. Again, this is likely due to the fact that infants and toddlers cannot utilize the fight or flight response, whereas older children have that ability. And also older children, their bone structure is much more rigid. They're also larger, so the different changing mechanism of abuse is going to change as a child grows. What I think is interesting, though, is that I do not expect that a child that grows up in an abusive home will stop being abused once they reach a certain age. I don't think that's really the mechanism of abuse. I think that what you will see, and our study attempts to describe this, that you're going to see changing patterns as a child gets older. So particularly when we look at the adolescents, they had the highest rate of facial fractures and hand fractures. And I think that we see a lot of that in adult assault victims as well. So whereas the adolescents are able to either fight or run, so some of those can be defensive injuries as well that we're seeing, whereas the younger children aren't going to be able to put up any defense. I think this is a good use of big data in a sense, as that there's not as much described in the adolescents. And again, I think that's multifactorial. I think perhaps they're not receiving as severe of injuries, or the children have been in the system so long that they don't trust anyone, so that they're less likely to even say anything or to minimize what's happening. So using big databases like this can really focus in on a population that now we can increase awareness and hopefully increase prospective studies on this particular population as well.
Thank you very much, Hallie, for an excellent presentation.
Thank you all.
I'd like to thank Dr. Streck and Dr. Castle for allowing me to present the best practice guideline for trauma center recognition of family violence. Many members of the APSA Trauma Committee, through their membership in Pediatric Trauma Society, have been working on putting together screening guidelines for child abuse, for specifically child physical abuse. Sentinel injuries are injuries that are highly associated with child abuse. We can all agree that these injuries should prompt an evaluation for child abuse. There are various examples that have been validated within the literature, including bruising and certain traumatic brain injuries. Why is this important? What we know is that sentinel injuries are the harbinger of what's to come for the child. And if this is not recognized and the child goes back to their abusive environment, they're at a higher risk for sustaining additional multiple injuries, each one escalating in severity and potentially leading to death. So why did APSA become interested in this? One of the things that we recognized is that there was no standardized way in how a child is screened in trauma centers. This led to the publication of the APSA position statement on screening for child abuse and the role of the pediatric surgeon. Importantly, it defined the spectrum of traumatic disease that these children experience and made recommendations. This work and other work by the Pediatric Trauma Society led Dr. Randy Bird to explore the idea of putting together a TQIP, American College of Surgeons Trauma Quality Improvement Program best practice for the evaluation of child abuse. A couple of tenets that were important to this guideline. We chose to offer as a best practice selective screening. There's two different ways to look at screening. First is a blanket catch-all screening program for every single child based on age, development, presentation to an ER, and all of them get evaluated for child abuse. And this has been done in countries such as Holland, and the Dutch experts have recommended caution in terms of resource utilization for implementing this type of program. So instead, we have recommended a selective screening so that certain key findings, what we call red flags, trigger a child abuse workup. Importantly, and what Hallie has pointed out, is that there are several screening tools, such as the 10-4 Faces P bruising tool, certain high-risk burn patterns, as well as 3 validated abusive head trauma screening tools that are indicative of abuse, but there are none for skeletal injuries. As a quick example, the Mary Bridge Children's Hospital Screening Tool was included as an appendix in the TQIP Best Practice Guideline. Moving on to fractures, the TQIP Best Practice Guideline did take a look at and summarize the best available evidence looking at skeletal injuries associated with child abuse in children. It does seem that the majority of literature describes children under the age of 4. So Hallie has made a meaningful contribution to the literature looking at adolescent screening patterns. In terms of younger children, skeletal fractures can be seen as sentinel injuries in certain pattern types, such as rib fractures under the age of 3, femur, tibia, and humerus fractures under the age of 18 months, fractures in unusual locations, Hallie described hand and feet, also there is scapula, etc. And it is important to consider metabolic disorders when you're working up a patient who's presenting with a fracture. If these fracture patterns are noted, it is important to start a child abuse workup. It also includes a series of laboratory screenings. However, I have to emphasize that child physical abuse can still occur in the presence of an underlying metabolic disorder, and the mere presence of a diagnosis such as hemophilia or metabolic bone disease does not exclude the diagnosis of child physical abuse. Skeletal surveys are recommended, as well as a 2-week follow-up skeletal survey. The list of the different views of the skeletal survey are included in the next 2 slides, with the second slide demonstrating a limited skeletal survey 2 weeks later. In conclusion, the American College of Surgeons Resources for Optimal Care of the Injured Patient mandates a process to generally assess, screen, treat, or refer a child suspected of maltreatment in all Level 1 and Level 2 pediatric trauma centers. Similarly, the ACS Optimal Resources for Children's Surgical Care advocates for a child abuse team to be available full-time for both Level 1s and Level 2s. All states, including the District of Columbia and U.S. territories, have laws about mandatory reporting for child abuse. We do recommend a selective screening process for child physical abuse in all trauma centers. It is important to note that there are still no overall tools that are validated for skeletal fractures as well. And trauma systems are poised to recognize child abuse injuries and provide a system of coordinated and standardized care for these most fragile of patients. Writing team. Thank you very much, and I'll be happy to entertain any questions.
Dr. Escobar, excellent talk. My question for you is, what do you see as the role of the pediatric surgeon in screening for child abuse?
Thank you, Chris. I really appreciate that question. I think that one of the reasons that APSA spent the time to create the position statement is that we believe that pediatric surgeons are perfectly poised to be the trauma team leader for the screening, evaluation, and management of these kids. We took the hypothesis or the theory that the level of injury that can occur in these children warrants the use of a trauma system. If we can standardize our approach to the screening and management of these children, we're going to see better outcomes. Based on that, we came up with a table that is published within that APSA position statement that highlights the different areas that we as APSA recommend in terms of screening for these kids. And the pediatric surgeon is the trauma team leader, but it is a multidisciplinary approach to how we manage these kids.